So we're going to present the next speaker, Dr. Giorgio Tabanella, and he will be discussing more advanced cases with augmentation procedures and the use of the Osstell technique in those situations. Dr. Giorgio Tabanella graduated from the University of Southern California, where he obtained the certificate in periodontics, as well as the Master of Science in Craniofacial Biology. He was awarded with Outstanding Periodontal Graduate Student Research in Surgery and Implantology by the California Society of Periodontists. He is also the scientific coordinator of the International Implant Conference and director of OREC, and also reviewer and author of original articles published in peer-reviewed journals. Dr. Tabanella lectures more or less all over the world and is also in the US on implant and periodontal surgery, aesthetic management in dental implant and periodontal therapy, peri-implant bone remodeling, soft and hard tissue reconstruction around natural teeth and implants, and also especially retreatment of failures of previously patient treated. His research focuses on tissue regeneration and augmentation with different bone and soft graft materials, peri-implant and dental bone loss, novel protocols for repair of failing dental implants. And he maintains a private practice in Rome, where he also holds advanced courses and live surgery on tissue regeneration and different techniques. So, a round of applause for Giorgio, and please, the stage is yours.
Thank you very much, Marcus, for this kind introduction. Good morning to all of you. Please allow me to thank also Osstell for this kind invitation today. The topic of my presentation will be focused on the clinical application of Osstell in cases where there is a need of retreatment, or cases where we had, for example, failures, or cases where, bone grafting or soft tissue grafting is not an option. So we can start manipulating peri-implant tissues at the time of extractions. For example, when we do immediate placement, we can simultaneously perform also guided bone regeneration. We can do soft tissue manipulation at the time of uncovery. We cannot certainly do bone augmentation at the time of the uncovery, but certainly we can manipulate soft tissue. And what we have been doing for the last 2-3 years, when we have very advanced, difficult cases, and I'll share with you this case at the end of the presentation, we start manipulating bone graft before extracting hopeless teeth. In this way, we can speed up the overall healing process. So if we think about a case like this, which is characterized by failures in bone grafting, but also refractory periodontitis, uneven free gingival margin, mucogingival deformities, overhang restoration, this is really a summary of several failures together. The diagnostic phase is the most important one. Then the second goal would be to achieve a good tridimensional thickness of the bone to allow our implant to be inserted properly and to leave a nice buccal bone balcony. Then, of course, the second step will be to manage the soft tissue in such a way that with minimally invasive approach, because we cannot certainly do CT graft on every single implant site, but we need to achieve a nice thickness of the soft tissue, not only for aesthetics, not only to provide the prosthodontist with something that can be easy to play with in order to get the illusion of the papilla, but also to create a nice soft tissue sealing around the neck of the implant. I think it's going to be really the future modern implant dentistry. Then at the end, we would like to achieve biomimetics, meaning something that resembles Mother Nature, and maybe see these cases that are improving over time. So when there is a nice even blending and harmonization of bone, soft tissue, implants, and natural dentition. We do know from periodontal principles that we can achieve, for example, crimping attachment and give the illusion of the papilla because there is no papilla between two implants. But everything is supported by the bone architecture that was reconstructed before. And we can achieve this on a very predictable base, and we can calculate this by using also digital tools. So we have been told that if we have an ISQ value less than 60, ISQ, of course, measure the implant stability by using Osstell, which is a standard of care in my practice. I've been using Osstell for the last 13 years. It's better to go for a two-stage surgery. When we get higher than 70 as an ISQ value, we can go for an immediate loading. This is predictable. But overall, if we have an ISQ value that goes from 57 to 82, we're on the safe side, meaning that we can decide to go for a delayed loading or immediate loading, but certainly we have an objective measurement that can be controlled. Going back to grafting, because we're focusing just on grafting cases, that's an example of a block graft failures. an implant also that failed. So this patient came to me with this vertical discrepancy. If we don't graft, we're going to have uneven free gingival margin between the two central incisors. But then it's very important also to have enough bony structure, not only for implant placement to get the primary stability, but also to create what is called the buccal bone balcony. This buccal bone balcony is going to support also the soft tissue. It's going to change the appearance also of the soft tissue. And this is very, very important. And we have seen that this thickness is most likely related also to the RFA measurements. But we do know also, based on the literature, that if we have, at the time of implant placement, at least 1.4 millimeter of vital bone surrounding the implant, that implant is less likely to show per-implant bone loss up to 10 years. That's a beautiful review published by Spray several years ago. That's one more reason to do GBR, maybe with a simplified approach, maybe by using resorbable collagen membrane, but in order to get the buccal bone balcony and to get that thickness. That means long-term stability of what we do. We need to graft also a case like this when there is no other option. Of course, I'm always looking for alternatives, but here, honestly, there's no alternative to vertical ridge augmentation. We need to graft also when the residual bone is left in such a position that if I follow the implant insertion based on the residual bony anatomy, like for example in this case after orthodontic uprighting of the lower left mandibular molar, I'm going to create a lever, I'm going to create a linguobuccal cantilever, and this implant is going to fail over time because of occlusal overloading. So here we need to place the implant in the prosthetic-driven direction. So no other option to grafting. Maybe we have an option to use different surgical technique for bone grafting. So overall, we are going to look together at some cases with increased difficulties in terms of bone augmentation, and now I do use the Osstell measurements to improve my self-confidence, because confidence really is the most important keyword today. The soft tissue, again, is supported by the bony architecture. I need to share with you my statistics. I have to place implants in augmented bone about 85% of the time. So I'm dealing with native bone in less than 15% of my implant cases. What I've seen over these years, this is just a mean, just an average, if at the time of implant placement, my implant is placed in a previously augmented bone, the RFA measurements tends to be higher, with an average of 80, 81. Whereas when I'm placing implants in native bone, the RFA, and again, that's an average, just descriptive statistics, tends to go down to 65. Then the two type of RFA tends to have a different behavior. In grafted sites, it tends to remain pretty much stable compared to the day I've inserted the implants. Maybe this slightly decrease, it goes down to 79. When I'm placing implants in a native bone, this RFA measurement tends to increase. It goes up to an average of 70. So if I go back to this graph that was explained very into details by Dr. Eckert, that's the trend that I see with native bone, and this is the trend that I see in grafted sites. So what does it mean? That generally speaking, what I find after our technique for guided bone regeneration, the augmented bone has a higher bone density compared to the native bone. So let's start looking at some cases where we can really understand how we can use Osstell. That's failures of the central incisor due to endodontic failures, of course, but we're dealing with a very thin biotype. Biotype is really one of the most important surgical variables that needs to be evaluated prior to implant placement. So here, there is a hover angle restoration also. There is a swollen free gingival margin. So what is going to happen if I do immediate placement, for example? What about if I'm going to lose 1 millimeter of soft tissue in the vertical dimension? It could be a disaster in terms of aesthetics, and she's just 27. So there's nothing wrong to do one step at a time, even if the buccal plate was left intact. It's 3 millimeters above the free gingival margin, which is an ideal position for the buccal plate. The tissue are thin, very thin. The biotype is almost transparent. So I do maxillary preservation, not to augment the sites, but to prevent the buccolingual collapse, or to reduce the risk of the buccolingual collapse. Then I deliver the immediate Maryland bridge. Now, only after 2 months, I have the bone formation, which of course is not mature, that is there, so I can calculate my osteotomy site preparation by leaving at least this 1.4 millimeter of vital bone on the buccal. Of course, the ISQ value is low, it's 57. I'm not going to do immediate loading here. But only after 3 months, we see that the ISQ goes up to 78, make me feel comfortable to deliver then the provisional first and then the final restoration. The soft tissue was manipulated just with roll flap, so minimally invasive procedures in order to get this mucosa that is very, very thick. And this is even thicker compared to the neighboring dentition. Then I reconstruct the convexity of the neighboring central incisor, and this thickness is very important because we do know today that this is going to influence the stability of the peri-implant bone maintenance. Then I deliver the zirconia abutment, and that's the final restoration, full ceramic final restoration. So we are thinking about improving the self-confidence, that it's a key word is used by Osstell all the time, and it's something that I use myself all the time. That's how it was before, and that's after. We overall lost a couple of months just waiting for the healing after the socket, or the healing of the socket after socket preservation. So let's move on now. Let's start looking at another case. Still, I'm not dealing with dentulous crest adhesions to teeth with a reduced periodontium. That's even more difficult cases. That's a very common congenitally missing bilateral incisor. So a patient went through orthodontic treatment, then she was referred to me because of this buccolingual collapse of the ridge, which is very common when the lateral incisors are missing. And of course, here we can already tell just by palpation, by the clinical examination, and of course, by our tridimensional reconstruction, that there is a need for bone grafting. But digital tools are a great help for me, even more for as a diagnostic tool. Here I can measure exactly that I'm missing 3 millimeters in the buccolingual dimension in terms of bone, but I could see also that there is a root proximity. That's why I asked the orthodontist to finalize the uprighting of number 9 and number 13, or number 21 and number 23, and I used the 6 months the orthodontist needed to finalize the orthodontic treatment to do my bone grafting. That's a simple, straightforward case that it can be done simultaneously with implant placement, but I didn't do it just because I wait for the orthodontist to finalize the case and to create for me enough mesodistal width to place the dental implants. So here we can see that we're missing the 3 millimeters that we could measure before raising the flap. And remember the concept of having this buccal bone balcony to support also the soft tissue. So here I did the full thickness flap, no vertical releasing incision, and the bone was harvested from the anterior nasal spina mixed with biomaterials. I used then the Krios Xenoprotect, which is a resorbable collagen membrane, and I don't need to use pins or screws because I'm dealing with self-containing defect. So this is really a straightforward case. Then, of course, I have to use special suturing technique to squeeze down the membrane and maintain the bone chips stable for a period of 6 months. So that's the anterior nasal spina, where the bone was harvested from, which is one of my favorite donor sites when I'm dealing with the premaxilla. And now, after 6 months, we have a bony architecture that's completely different. Now here we see the augmented bone, and I can measure and calculate all my surgical variables. And based on the anatomy, I can even look at the implant that I'm going to choose in order to get the highest primary stability as possible. So what is happening in the daily practice when we do this type of bone augmentation? We do see a bone density that is resembling the bone density of the donor sites. So where I took my bone chips from, which is generally the anterior nasal spina or tori or the ascending ramus. And I need to use osteotomes here. This was during live surgery in Rome, just to compress the native bone, which is softer compared to the augmented bone. So the osteotomes are used just to compress the native bone. The initial preparation of osteotomy sites is done by the combination of twist drill and taper drill, always trying to under-prep the sites a little bit so that I can give the prosthodontist the chance to eventually do immediate loading. The implant is going to be inserted, and here it's very important to look at the ISQ values, of course. So that's the previous measurements that was done on the previous patient. Now we're going to measure here the mesiodistal ISQ value, which is 80, as you see here, and then I'm going to measure also the buccolingual, that's still 80. So this is a classic case that even if we did gut bone regeneration, patient can move to immediate loading if we want. So the time that it was needed for bone reconstruction is the time that we might use for immediate loading. So we can still speed up the healing process. So that's a summary of what it was done. And here again, we're dealing with very simple, straightforward case because the neighboring dentition doesn't have any kind of periodontal attachment loss, which means that when I'm going to sculpture my soft tissue and trying to give the illusion of the natural scalloping, I can apply a lot of pressure without having recession on the neighboring papilla. That's before and after. And that's how we start sculpturing everything. But again, here it can be done because I have intact periodontium, so I apply pressure just with a provisional. The bone that I was able to augment with gut bone regeneration is supporting also the soft tissue. But that's a healthy periodontium. So if we raise the level here, we start looking at the dentures crest adhesions to teeth with a diseased periodontium, meaning teeth that have been treated for periodontal disease or teeth that have, for example, mucogingival deformities or failures or complication or iatrogenic even dentistry. What do we do? So we're always looking for protocols and classification because they are of help for clinicians like us. But in gut bone regeneration, timing can be an issue, and we need to individualize each case. So to me, the only way to individualize and customize every single healing process and to understand which is the proper time to load that implant after manipulating hard and soft tissue is by using Osstell, which is the only dynamic way to check the implant stability. So let's see together this case, for example. This patient had a traumatic extraction of the canine, followed by bone graft that failed, followed by another surgery with simultaneous bone grafting and implant placement that failed again. She's showing, of course, mucogingival deformities here. We can see that there are also recession on the neighboring dentition. They look like minor recession. The lateral incisors had mobility class 2. So my initial diagnosis was based also on the periodontal assessment of this patient. So number 12 doesn't have a good prognosis, and it's going to be extracted after eventually gut bone regeneration. So if I try to imagine, if I try to visualize what is going to be my final aesthetic results, and I compare already the emergence profile, I need to have in mind before raising the flap, we need really to know where we are going. Of course, the soft tissue is absolutely flat. It's not convex as it should be on the canine. Then the chances of getting the papilla here, it's almost close to 0. So already told to the patient, you know, you're going to have some kind of pink porcelain here. Then we take a very simple periapical x-rays. We see the tremendous amount of vertical bone loss. But here we have something that is making these cases even more difficult. That is called attachment loss on the neighboring dentition. So I'm missing the periodontal ligament, which means that I'm losing 1/3 the blood flow. So if I have to perform gut bone regeneration in these cases, and I don't have the periodontal ligament of the neighboring dentition, I get blood only from the gingiva, the periosteum, and of course from the endosteum. So 3D reconstruction is again of help because I can visualize the remnants of the previous bone graft that needs to be removed. I can see the entrance of the furcation of the premolar. If I lose 1.5 millimeter of bone, I'm going to lose the premolar too. But I can see the tremendous amount of bone lost on the palatal aspect of the lateral incisor and the widened PDL because the tooth was mobile. So what do we do here? So treatment planning was based on GBR first, then implant placement on the canine area, then extraction of the lateral incisors, GBR, placement of an implant in number 12 area. I had to do one step at a time because if I do extract the lateral incisor, I'm going to lose also the little bony peaks that are left. This case is also unique because generally we do have a buccolingual collapse of the ridge after extractions. Here there is a residual bony defect towards the palatal side. I have limitation due to the reduced periodontium, so I cannot go beyond the bone housing if I want to keep it safe and long-lasting, which is very important. How do we stabilize titanium mesh or titanium reinforced membrane here on the palatal side? That's another case where I use resorbable collagen membrane and a mixture of autologous bone and biomaterials. Then after 7 months, I place the implants. ISQ value 57. Of course, I'm not feeling comfortable. But what is going to improve my confidence are the ISQ measurements. Because at day 0, when I place the implant, after 7 months from guided bone regeneration, of course I have 57. This tends to go up to 64/69, which is not sufficient for me to make me feel comfortable. And then I wait 3 months longer, and I got 75. Now I did my transpositional flap to boost the biotype. That's based on periodontal principles. I delivered the final restoration. The lateral incisor was not extracted because with GBR we were able to compensate also for the bone loss on the palatal aspect of the lateral incisors. And then we got the crimping attachment, which is very common, very, very common. We can calculate that at 3 years that line it tends to disappear. And if we compare before and after, it looks like we did the connective tissue grafting. I didn't perform any kind of CT graft here. It's just soft tissue manipulations. And this tissue tends to get thicker and mature after a few years. So I left this space here on purpose in order to have the newly formed papilla, which again is an optical illusion. It is an optical illusion. And that's before and after. So here, without Osstell, I would feel really, really uncomfortable in performing this kind of rehabilitation. Let's move on. Let's face another case where I have a combination of advanced periodontal disease on the first quadrant, and then I have to extract the teeth on the left quadrant because there is a long bridge connected with the wisdom tooth. This is not everything. We cannot just extract all the teeth because it would be easier. There is a huge, pretty large endodontic cyst due to, again, endodontic failures. The majority of these cases are based on failures, based on mistakes, and we can learn a lot from this. So this lesion is distalizing also the canine, but this lesion is approaching also the base of the nose, the piriform aperture. So if I already know that I have to perform guided bone regeneration, sinus elevation, if I approach this cyst by removing the buccal plate, I'm going to lose all my bony peaks that are so crucial for guided bone regeneration. So I did a tunnel approach that is quite demanding. I remove all the cyst, and then I start grafting the sites, starting from the mesial aspect through the tunnel. Try to preserve. By doing so, we did a repair of 1.5 centimeter of bone loss, which was due to the endodontic lesion. Now, we had to think about the final aesthetic results. If I have natural dentition on the right-hand side, and then implants, I'm going to have implants on the left-hand side, I have to think already about the free gingival margin and the final aesthetic appearance of this patient. So we did periosurgery, and of course aesthetic crown lengthening, but also the treatment with osteoresective surgery of periodontal disease. Now we have to face the second quadrant, where we have this knife-edge ridge. The mucosa is really, really poor. The 3D reconstruction is showing this defect, pneumatized sinus also. So what do we do here? To make the long story short, I did simultaneous guided bone regeneration and sinus elevation with the use of resorbable collagen membrane again, the use of Krios Xenoprotect. And here the bone grafting was Krios Xenogain. Then implants were placed after 6 months. And then I did extra boosting to get the buccal bone balcony. Now you can see that all the 4 implants are placed within augmented bone, all of them, except for the mesial, which is placed in contact with native bone on the palatal aspect. Which is the best time to load these implants? Really, I mean, it's something that we need to figure out. So we tend to use longer implants, which does not exceed more than 13 millimeters, because we have seen that we got higher ISQ value when we have longer implant. There is a positive correlation. But we know also, that's a Sennerby study, that if we use longer implant than 13, we don't get necessarily higher ISQ value. So I stay maximum to 13 millimeters implants. That's my philosophy, okay? That's my personal view. So that's at the time of uncovery. I had to remove the pins. I had to remove some bones that's covering also the head of the implant. That's the ISQ value, 68, 79, 75, amazingly 81 where I did sinus elevation. The mesial one is showing 68. It was the only implant placed with osteotomy site towards the palatal aspect in contact with the native bone. And that's what I see, what I've seen in the last really 13 years, lowest ISQ value in contact with the native bone. Now at this stage, I can do my soft tissue boosting with no CT graft again. That's plastic surgery that I did to boost the tissue, to increase the thickness, and to make our life easier. The thicker it is, the better it is. Then I wait at least 1.5 months before I go on with the definitive impression. And if anesthetic areas, I wait even at least 3 months. But now, this time, it gives me even more confidence because I see that ISQ measurements are stable where I did my GBR procedures. And the one on the mesial is increasing up to 70. And this is very important because when we're treating these advanced cases, I would like to have an objective measurement telling me if I'm the right track or not, telling me if I have to wait a little bit longer or not. And we cannot generalize, we cannot follow just general protocols. These are just unique cases. And this is the final result. But there is an increased demand for reducing the healing time. So we live in the era where when we had to perform gathered bone regeneration or bone augmentation, soft tissue plastic, we need to be minimally invasive. And we need to reduce the healing time. Let me show you this case, how we are changing the approach here. This tooth was dyschromic. That's a very, very complex case. I'm going to summarize in few slides. And there is open contact, is lingualized. This patient had trauma 20 years before. Here we can see there are endodontic failures, endodontic lesion. This is not everything. Endodontic lesions you can see here. Very wide, large nasopalatine canal, external root resorption. This tooth doesn't have a good prognosis, it needs to be extracted. What about if we do the extraction of this tooth? And there is a very tiny buccal plate, there's almost nothing there. What is going to happen to the ridge? We're going to have a tremendous collapse of the ridge here, especially if you think that there is even no chance here to place a dental implant because the basal bone is wide, only 2 millimeters. As you can see here, the nasopalatine canal is very, very wide. If we do the extraction of the tooth, this bone is going to collapse. So I'm going to have multiple problems related to socket collapse, then the anatomy, and endodontic lesion. We changed completely the protocol. Of course, we had to do endo retreatment, even on this case that was going to be, where the tooth was going to be extracted. I did gathered bone regeneration prior to tooth extraction. Of course, I don't have to have any kind of infection. Again, the same technique, the same approach, minimally invasive. By using resorbable collagen membrane, there is no risk of exposure. So we reduce also the risk of complication in gathered bone regeneration. And that's a pretty big graft on this patient before extracting the teeth. Now, after 4 months, only 4 months, I can rely on the bone that was augmented on the buccal plate. So I know that I'm going to have bone on the buccal plate. So I did the extraction. So that's before the day of GBR. 4 months after, I did the extraction of the central incisor. The implant was immediately placed. ISQ value 69/75. Of course, in the buccolingual direction, there is no contact with the residual bone, but still it's very high. It's very stable. Another GBR procedure with a minimal invasive approach, immediate provisional, and immediate loading of this case. And this is the final results. So here we can see a close-up of the bone surrounding the neck of the implant, which is stable over, actually we have a follow-up up to 1.5 years for these cases. And this is the final appearance of the soft tissue. So overall, it took us only 7 months to treat this case. And with this, I thank you very much. Thank you.